GISTs are mesenchymatogenic neoplasms with an annual incidence of 6 to 22 cases per million. 60 to 65% are in the stomach and 20 to 25% have a clinically malignant behavior. Both sexes are equally affected, although there is a slight male preponderance. They are considered an old age disease as the median age at diagnosis is around 60 to 65 years old. The vast majority are sporadic, but sometimes they are part of syndromes like von Reckliausen neuronematosis, Carney-Stratocki syndrome, or Carney's triad. They originate from the interstitial cells of Cajal, which are located in the myenteric plexus and function as the pacemaker of the gastrointestinal tract. In 90% of the GISTs, genes encoding tyrosine kinases are mutated. In up to 80%, these mutations concern cluster differentiation 117 kinase, commonly known as c-KIT, and in up to 15% of the cases the mutations concern the receptor of the platelet-derived growth factor. Both are type 3 receptor tyrosine kinases. Normally, ligand binding leads to dimerization and kinase activation. Mutations obviate the need of ligand binding and cause constitutive activation of the ETV1 signaling pathway, through the RAS, MEK, MAPK and the PI3K, mTOR pathways. The subsequent blockade of apoptosis, and induction of cellular proliferation turns the interstitial cell of Cajal into GIST. Type 3 receptor tyrosine kinases are transmembrane proteins. They are comprised by an extracellular ligand binding domain, the transmembrane part, and the intracellular part, which consist of a juxtamembrane domain, an ATP binding region, and an activation loop. Mutations of exons 9, 11, 13, and 17 of c-KIT, or of the exons 12, 14, or 18, of PDGFRA, lead to receptor dimerization, activation, and stabilization of kinases in the active form, independently of ligand binding. With regards to gastric GISTs, typical mutations are those of exons 9 and 11 of the c-KIT, and of the exon 18 of receptor A of the platelet-derived growth factor receptor. In approximately 10% of the GISTs, no mutations of the c-KIT or the PDGFRA can be detected. Therefore, these GISTs are collectively called wild type, but they can be divided into two categories, those that are succinate dehydrogenase deficient, and those that are not. Succinate dehydrogenase deficiency derives from epigenetic changes. Hypermethylation of the gene's promoter leads to downregulation of the enzyme, incomplete oxygen consumption, decreased energy production and, through the Warburg effect, to an increased neovascularization. GISTs deficient in succinate dehydrogenase are part of the Carney-Stratocki syndrome and Carney's triad. This triad consists of GISTs, paragangliomas, and pulmonary chaudomas. Wild-type GISTs that are succinate dehydrogenase proficient harbor BRAF mutations, or mutations of the neurofibromin gene. Alternatively, they may be due to translocations affecting the genes of neurotrophic tyrosine receptor kinase, NTRK, or of the receptor of fibroblast growth factor FGFR. Wild-type gastric GISTs are either SDH deficient, with the typical hypoxia-associated angiogenesis, or they carry the BRAF mutation. In gross pathology, GISTs are well circumscribed, gray to white, or red-brown tumors. They develop within the gastric wall with a submucosal, or subserosal projection, or both. On microscopic examination they are usually comprised of spindle cells. Less often they have an epithelioid morphology, but mixed types also exist. Microscopy guides diagnosis, yet immunohistochemistry offers the necessary confirmation. Expression of CD117 and DOG1 are the most helpful diagnostic indicators. Less useful, but commonly checked, is CD34. To exclude other diseases, smooth muscle actin, S100, and desmin, should also be evaluated. Non-expression of SDH beta characterizes SDH deficient wild-type GISTs. Malignant GISTs spread locally or hematogenously in up to 50% of the cases. Metastases involve most often the liver, the omentum, and the peritoneal cavity. Lymphatic dissemination and lymph node metastases are extremely rare. These are met typically in the wild-type GISTs like in the Carney-Stratocki syndrome or in pediatric cases. GISTs clinical course can be asymptomatic for a long time, especially when they are small. Symptoms develop when their size increases and lead to their detection in 60% of the cases. A significant proportion is detected during surgery, and 10% during autopsy. This data, however, is based on old series and may have changed nowadays. When symptoms appear, they are nonspecific, leading to a delayed diagnosis. Most often they are due to the mass effect exerted by the tumor. The patient may complain of abdominal distension, discomfort, or a vague abdominal pain. Early satiety is also frequently reported, and occasionally a palpable mass can be felt. Mucosal ischemia, due to stretching by the underlying mass, may lead to ulceration and bleeding. Chronic blood loss can lead to anemia and fatigue. Not infrequently though, significant hemorrhage may occur. This can manifest as melena or hematmesis or even hemoperitoneum in the case of tumor rupture. Laboratory workup may reveal anemia in case of blood loss. A filling defect with obtuse angles at margins is seen in barium meal. The mucosal surface is typically smooth, but signs of ulceration can also be seen in relevant cases. Ultrasound is not a routine examination for GISTs. However, if performed, it may reveal a hypoechoic homogeneous mass. In case of necrosis or hemorrhage, mass heterogeneity will be seen. In endoscopy, the intraluminal projection of a submucosal mass can be seen. The mucosa will be smoothly raised by the underlying mass similarly to a tent. Biopsy of the mucosa will be inconclusive as the lesion lies deeper in the gastric wall. Bite-on-bite biopsy sometimes can be diagnostic though. At times, the mucosa ulcerates if overstretched by a large mass. Endoscopic ultrasound will depict a hypoechoic mass. This will typically be homogeneous, but in the case of intramural necrosis or hemorrhage, heterogeneity is expected. EUS-guided FNA will provide tissue for diagnosis and prognostication. Triple phase water CT, i.e. in the non-contrast, arterial and venous phase, will show the hypervascular, enhancing mass. It will be heterogeneous if necrosis or hemorrhage has happened, and it will displace adjacent organs. High-grade cases, however, may infiltrate adjacent organs. Multiplanar reconstruction can offer useful details for the operative strategy. Mucosal ulceration can also be detected. Employment of gastric distension protocols and mild opacification with water, as described in the adenocarcinoma chapter, are extremely helpful. MRI has a comparable diagnostic yield compared to CT. However, it lacks radiation exposure and it can be applied to those patients who cannot receive intravenous CT contrast. It is the modality of choice in patients with suspected liver metastases, but its yield in mesenteric lesions is poorer. PET-CT does not replace CT or MRI as the initial imaging modality of choice. However, it is useful in detecting disease dissemination, disease response after systematic treatment, and disease recurrence after surgery. GIST's prognosis depends on the size of the primary, and the number of mitoses per 5 square millimeters. This is an indicator of the cellular proliferation rate. This information has been incorporated in the UICC TNM staging system. Tumors smaller than 2 cm are considered as T1, tumors between 2 to 5 cm, T2, 5 to 10 cm T3, and larger than 10 cm are T4. Lymph node involvement and distant metastasis follow a binary pattern, either 0 or 1. Mitotic rate is also incorporated and classified as high if more than 5 mitoses exist in 5 square millimeters. As it can be seen in this table, disease stage is basically decided by the T stage and the mitotic rate, while positive lymphadenopathy or distant metastasis classify the disease as stage 4. An easier to remember table derives if we classify the disease according to mitotic rate. In this manner, the significance of cellular proliferation rate is easily understood. Treatment of GISTs depends on the size and the resectability of the primary. All symptomatic GISTs, and those larger than 2 cm, should be forwarded to upfront surgery if they can be resected without major morbidity. On the other hand, microgysts smaller than 1 cm can be safely observed without any intervention unless needed. GISTs of intermediate size should be controlled for worrisome features. These include border irregularity, ulceration, echogenic foci, heterogeneity or cystic degeneration. If such features do not exist, then they can be followed up by imaging at regular intervals. Otherwise, they should be forwarded to upfront surgical resection. Patients expected to have a highly morbid resection, or needing multivisceral resection, and patients suffering from metastatic or irresectable disease need systemic treatment. If they respond to treatment favorably, surgery might be an option. Resection should aim at the removal of at least all macroscopic disease. Ideally, an R0 resection, with negative margins of 1 to 2 cm, is desired. However, there is no difference in the oncologic outcome between the patients who had R0 or R1 resection. In contrast, it is of utmost importance to avoid the rupture of the tumor during resection. Rupture and subsequent tumor seeding decreases dramatically survival rates, and diminishes the chances for cure. The surgical approach can be either open or minimally invasive. They have the same oncological outcomes and similar morbidity, so minimally invasive surgery is the preferred approach, provided that expertise is available, and that the size of the tumor will not require a large incision, abolishing the benefits of minimally invasive surgery. Despite the surgical extirpation of the disease, a significant percentage of patients will suffer from recurrence, or metastatic, or non-resectable disease. Radiotherapy and classical chemotherapy have no effect, so they are not part of our armamentarium. In contrast, targeting to the activated tyrosine kinases with kinase inhibitors has proven of value. Although it is beyond the scope of this lesson, a brief description of these agents follows. Imatinib was the first agent known to selectively inhibit c-KIT tyrosine kinase. 400 mg daily is effective, while the dose can be escalated to 800 mg daily when resistance develops. Resistance to imatinib can be surpassed with sunitinib. This inhibits all 3 kinases, c-KIT, PDGFR, and VEGFR. A dose of 37.5 mg daily is the preferred second-line option for patients with unresectable, progressive, or metastatic disease previously treated with imatinib. Sunitinib is also indicated in SDH-deficient wild-type GISTs. If resistance to both imatinib and sunitinib develops, then these patients with advanced disease can be treated with regorafenib and then with ripretinib. For the selected group of patients who suffer from unresectable, progressive, or metastatic disease, and carry DV842V, or other PDGFRA mutations on exon 18, which are resistant to imatinib, avapritinib is indicated as first-line treatment. If they carry BRAF mutations, they should be treated with the combination of dabrafenib plus trametinib, while patients with fusion of the NTRK gene should be treated with larotrectinib or entrectinib. Finally, patients that are not able to tolerate surgical resection of their liver metastasis can be treated with cannulation of the hepatic artery and transarterial embolization, or chemoembolization, or radioembolization. Or they can be treated with image-guided percutaneous ablation if they fail to respond to TK inhibitors. Needless to say, that all patients should be thoroughly discussed in multidisciplinary meetings prior to any decision on their treatment. This principle cannot be overemphasized. Post-operative systemic therapy is indicated as adjuvant treatment in patients with high-risk disease. It should also be considered in individual intermediate risk patients. Candidates are patients with lesions larger than 10 centimeters, or with smaller ones characterized by more than 5 mitoses per 5 square millimeters. Similarly, adjuvant treatment is needed if an R0 resection was not achieved, or if the tumor ruptured during surgical manipulations. Finally, adjuvant treatment should be considered as continuation in those patients who had preoperative treatment. Typically, a dose of 400 mg daily of imatinib for 36 months is given. It can be escalated to 800 mg if resistance ensues. When the disease is resectable but a high postoperative morbidity is anticipated, preoperative, neoadjuvant treatment is indicated. In this case, imatinib is prescribed for a period of 6 to 12 months, aiming to decrease the size of the primary, and to allow a less morbid resection. Patients with non-resectable disease should be offered systemic therapy. If the disease responds and becomes resectable, surgical consultation and perhaps resection should be offered. The same strategy with systemic treatment and reevaluation should also be considered in patients with primary metastases or recurrence. If complete resection can be obtained, the prospect of surgery should be taken seriously under consideration. Cytoreductive, debulking surgery is still under investigation and should be offered only in the frame of clinical trials.